So for everybody, I've got my hands off the reins. My main mentor of life, Dr. Stephen Pearlman, who's the master of facial plastic surgery in New York, revision rhinoplasty, and he was my professor at Columbia University and the one that really got me into everything. So he's running today's session and wants to grill me about why I do facelifts the way I do.
Well, I will start off with you. I've known Ben for a long time. Met him back when he was a resident, stirring up trouble.
Yep.
To go over his academic background, he, in a true LA fashion, you want to cover both bases. He did undergrad at UCLA and med school at USC. So
UC San Diego.
San Diego. Okay. This way, he covered most of the state. Then he came to New York. We were lucky to get him. And I was a professor teaching facial plastic surgery to the otolaryngology residents. And because it's no longer really that busy in hospitals, they have to go outside. So I arranged it so residents could come to my practice and see me do facial plastic surgery, do cases, do studies. And Ben took more advantage of this than any resident in the history of the program.
Ever?
He would find time post-call between cases. If cases were canceled, if he was calling in sick, there he was showing up. And he was, he asked great questions. He was interested. And so I gave him a project to do. That's how you get started. You do projects, you write papers. And I gave him revision rhinoplasty because when you have a good resident, they can do a lot of the legwork. Well, he did a lot of legwork. He wrote a pretty damn good paper that I was senior author, and I gave him most of the main technical details, but he grasped it at a very young age. And then after I grilled him, got him started in facial plastic surgery. No, I didn't. He didn't pay me to say that. So I then sent him over to my good friend, Andrew Giacono, who is another really superb surgeon, does fantastic facelifts, loves to teach. So I guess I'm sort of your academic father for rhinoplasty, and your other side was Andrew Giacono for facelifts.
Yeah, and
So
that article that we wrote, it actually comes up a lot by residents. So there's a lot of residents who contact me and say, you know what, I'm going through my facial plastics rotation, and the chart that we had. They say your chart is amazing because I get quizzed every day by my attending, and that chart guides me as to like what to say when they're like, okay, well, what do you do for an over rotated tip? Yep. What do you do for an under rotated tip? So they use it from there, and we actually turned it into a book chapter too.
Mm-hmm. Yeah, well, it worked out nicely, and that's what I like. I like teaching the concept called lessons learned in revision rhinoplasty. So because you can't just go and talk about it, you're teaching mostly younger people who want to learn the operation right. So they say in medicine, the best treatment is prevention. So if you learn what are the most common things that can go wrong, hopefully prevent them from happening in the first place. Let's get it. Well, we're going to come back to rhinoplasty later, and millionaire hair. We don't always have to break the nose, but it's the most fun part of the operation. No, I'm just kidding. No, it's a subtle part of the operation. It's about 5 minutes in the 2.5 hour operation, and we can go into more details about another talk when talking about rhinoplasty. But now we want to talk really about facelift, and so you like doing something called it's a deep plane facelift, and you tag the AuraLyft, which is your personal twist on the deep plane facelift. But what it's great about deep plane facelifts is that you're really releasing everything and putting it where it used to be, as opposed to trying to stretch it and move it where it shouldn't be because it's still attached. So in 20 words or less, why is the deep plane facelift superior to other facelifts?
The face is not built like a house. It's not wood with screws that kind of drill into place. So if you're going to take something up, you can't really drill it into place. You have to have it be tension free. So it's kind of like redraping a rug or a blanket or something like that. You don't want to drag it when there's attachments or Velcro under it. You want to release all the Velcro, get it into a new position, and just tack it down. And now what we've figured out is we don't just age in the skin, so it's not a rhinoplasty like it used to be. You have to actually lift everything that drooped. And so it's logical. I mean, everything drooped this way. You want it to go back up. The only way to get it to stay there is to release it from its base. and then take it back up and put it down.
So that's the key to the deep plane. You're releasing it, and I'll tell people that when someone looks pulled or has the Nike swoosh, you say, oh, they had too aggressive facelift. As a matter of fact, their facelift wasn't aggressive enough, because without the release, you're trying to pull the skin when it's tethered. And so when people say, oh my God, I heard the deep plane facelift is very aggressive. No, it's a more comprehensive operation.
Mm-hmm.
And so when you release these ligaments, what is it? I mean, do you have to squirt fat with every facelift like people who don't do deep planes do?
No, because now you're actually repositioning the fat pads and getting them up. And when the volume goes, the facelift doesn't fail anymore. So now we're going in, we're releasing everything. And the best part about this is all these research studies have been done over the past like 50 years about which direction, and the argument about pulling lateral, superior, vertical, posterolateral, 45 degrees. The argument or that whole conversation is gone. It doesn't matter anymore, because you don't need to determine where to pull the face. The face droop this way. If it relaxes and releases completely, wherever your hands pull, it will go to the maximum kind of the vector of descent. So wherever it came down, when you release it, it'll go back up in that vector. So you don't have to determine a vector anymore, which is the real benefit of these kind of things. Is you don't have to use brain work. You go release everything, and the body will tell you where it wants to go, because that's where it aged from. So you're not picking a vector. You're not going to make someone who aged this way younger that way. That makes no sense.
Right. So we're putting things back where they used to be. And so what happens? Why are people putting fat up here in the cheeks?
So some people blame everything in aging of the face on fat loss. Those people generally have an inability to lift. If anybody has the ability to lift, they start to blame it on drooping mainly, because they see that when they lift it, so much more is corrected than when they volumize, which means that the cause of it is more than anything is drooping. So I'm able to release and bring everything back up and revolumize the upper cheek by taking everything that descended off of it, because the cheekbone stays here, but the cheek tissues fell down in front of it. So now your volume is localized here. We release it, we put it back, all of a sudden their contour is restored. Not 100%. So some of them do need some volume, some people more than others. Some people, even after you replace the volume as much as you can, they still have skin quality issues. And it's because you're not replacing their natural volume, you're replacing it with something else. It's not, the actual layer that it was lost in, you're mimicking it. But that's the reason that these facelifts look more delicate while looking more dramatic. You're getting a much bigger change and improvement, but in a more delicate way. You're not getting this big puffy face, or even amongst the best facelift surgeons that I've seen who are very well known, they tend to masculinize people because they have to get rid of all these shadows over here and they can't lift them enough. So they volumize them. And when you add all this volume to the lower face, it gives you either a simian or a masculine appearance. Mm-hmm. And I see a lot of very famous surgeons doing that. And so I always say that their patients look like very wealthy masculine women. And that's really what you see. And in guys, it works out fine, but not in women.
Because I found I got an appreciation for the cheeks I created deep plane facelifts after we started doing cheek fillers. We had these nice volumizing fillers, such as Voluma and Wrestling Lift, and I started talking about cheek augmentation with deep placement of the fillers along the zygomatic arch, along the cheeks, mm-hmm. and making more youthful cheeks. All of a sudden, I look back at my deep plane faces I've been doing, and I started getting obsessed about it. I was like, oh my God, look how gorgeous their cheeks look. We always talk about, look at that neck, look at that jawline, look how fabulous she looks. But now I'm like, my eye goes right to the cheek. It's just maybe because I do fillers and surgery, that's something that I look for.
No, me too. And you look at people now and you think they look tired all the time. And so you combine this vision that you've had from surgery and from fillers, and now you want to make everybody look rested. You want them to look more contoured, more defined, and still delicate all the while. So we use fillers when we can, we use surgery when we can. And I feel personally that my understanding of facial aging mm-hmm. and what's needed in rejuvenation was not even half by surgery. It was more actually by doing fillers on somebody. So not that it's always the answer, but me doing the filler, staring at the face over and over again, seeing what needs to be corrected, and seeing where everybody else made this beautiful, delicate woman look bulky, manly, and like a monkey.
Right.
so, or like a peanut
Yep.
or whatever.
And when you, as you age, you also want to put fillers in different places. I mean, the young ladies want it out here. I actually call that runway cheeks.
Yeah.
As people get older, they want more restoring volume here because their cheeks have fallen. So either you put it up. Anyway, I happen to see a question pop up and said, "Do fillers lift?" They don't lift up; they lift out. So if you can make a more round, full cheek, it gives the illusion of lifting, but it's not really going to pull up a jowl. It's not going to pull up a floppy neck.
Right.
So you're not going to improve you can improve the jawline, but you have to fill in front of the jowl and then get exactly what you said before. You can get this square jaw. So unless she has a tiny chin and big jowls, by filling in front of those jowls, you're just going to make this big square masculine jaw. And the ideal face we talk about is, they say it's egg shaped. So, and they talk about how it should be, wider on the top or heart shaped and get slender on the bottom. In teens to 20s, 30s to 40s starts to flip, and it gets wider on the bottom, more masculinized, and narrow on the top. So we're filling the top, but as you said, if you leave a wide bottom by not lifting it, it's masculinized and square. And actually, I find that this egg actually goes just like how say little, babies look like little old men. Well, look at babies. Babies are like little old men. They have the big chubby cheeks down below and a narrow upper face, and then the little cheeks here. And then as you get older, they lose this volume. It comes here, and then it flips down. So it changes twice.
And you do see that with younger girls as they're in their teens. They're still in this baby fat face, which is rounded. And then they want to come get buccal fat removal. And eventually they start to go towards this, which is getting more angulated and heart-shaped. And then from that shape, then they start to sag, they become more square. And then the extreme of that is, as it comes down, they temporarily hollow and then get these kind of wide jaws. And the real masters at filling really learn how to manipulate all those shadows on the face. So back to the question about, can fillers lift? They can if you overexpand somebody. So if you injected balloon somebody out, yes, you can do that. But that's not a practical solution. So why do people do it? Because they have bad taste. So the masters at filling are magicians with shadows. They look at shadows. They really understanding the shadow. Why is the shadow forming here? Why is it forming here? And how come every time I have a patient with it here, they have it here? So they see those shadows, and they see that when they get rid of one of these, all of a sudden the shadow underneath it changes. So they don't have to put volume here because they started here. If they start here, then they have to put it here. Now you have double the volume that you need. So those are the tons of tricks and fillers. And with fillers, you're always adding volume to the face. When you add volume to the face, some people need it. Some people are just getting bigger and fatter faces. So I don't want my future wife to have a big fat face. I want to have a nice delicate face that it looks natural, it looks untouched.
Yeah, well, it's like as I say to patients, it's like the housewives of every city. They tend to give fillers a bad name. Now, you mentioned buccal fat. Now, I'm not a fan of buccal fat in young patients because you will lose that volume. But how often do you tend to address that in your facelifts?
It depends on the facelift. So if it's a primary facelift and it's somebody who doesn't have a tautic buccal, because the buccal fat pad, so for everybody who doesn't understand what it is, it's a rounded 1 or 2, 3 compartments, sometimes fat pad that's located here in the cheek in front of your masseter and kind of behind this marionette area. So it sits right over there. And it is a different type of fat. It's different than every fat in your face except for the orbit. This fat's the same. And some people have similar fat in their subplatysmal area, where it's this round, linear, beautiful fat that is kind of, you would call stem cell rich. Guy Mastery, for example, calls the eyelid ones also stem cell rich. And a lot of people do. And histologically, they look the same. So these are fats that you don't want to get rid of in your face because they're support structures, or you can use them for other things. So this fat pad, for example, is a support structure for the cheek, which supports everything below the cheek, which is this area. Okay, so if you get rid of the fat pad here, and you don't have excess. So you took somebody who has a normal sized fat pad, which is most people, and you get rid of it, all of a sudden this starts to collapse and they get a deeper marionette line. And they can get unnaturally deep, where you look at somebody and you're like, what? Why does it look so deep there? And you're like 25 years old, it makes no sense. And then you ask them, have you either been overfilled, so they put too much filler there, it's Juvederm, or have you taken out your buccal fat? And it's usually buccal fat. So the reason I would take buccal fat is somebody who has an overly rounded face. They're just always full, and they're always going to be full. And I've seen enough faces to know that this 20-year-old is always going to be full. Unusual, right? It's usually like the 30-year-old that I see who has already declared that she's not going to get rid of her baby fat. And then I can reduce them. And I like to do radio frequency on top of it, so I can take less fat out. I can take maybe half of it or a quarter of it out, and then I slim them with radio frequency. They keep the buccal fat. If I'm doing a face,
I'll rarely do buccal fat in someone that's under 30. I mean, if you have a really promising modeling or acting career and you do have a chubby face, and they know the consequences, yes. Otherwise, got to be at least 30 years old, and bring in pictures of your mom, your older sister, your aunts, and show that they maintain this fullness.
Yeah. So there are patients that I feel like this is where it gets dicey in being a doctor, where if they came to me and I had my choice, I would say, no, don't do buccal fat. Okay. But I know this patient and I know them very well. And I know the second I say no, it doesn't matter what I say, how I say it, what I convince them of, they're going to go somewhere else and do it. And this beautiful face is going to be destroyed. And I'm going to be so pissed off. So, and I know that's going to happen, and I'm positive. So now I have to step back a little bit and think about, okay, what are my odds here? I have to be more practical. So what I do for them is I do that. I say, you know what? I'll take out a little buccal fat. I'll slim your face another way with Profound. I'm going to keep you healthy looking and safe. And 20 years from now, you're not going to be upset, and you're still going to get the result you want. And later I can touch you up with a little bit of filler right here, a little bit there, and you're golden. No damage done.
What is Profound doing? So people, what is the technology of this Profound?
So Profound is it's a radio frequency treatment. So it means like a laser. These are energy-based treatments. Lasers shoot photons, light energy into the skin to damage it or cause some thermal damage, heat damage in there. And the radio frequency puts in modified electricity. It takes electricity, changes the current, puts it in the face, and it denatures proteins. It denatures the collagen, elastin, hyaluronic acid, those things, and it tells them, the body, to reform them. So overall, what you're getting is thicker, denser skin, tightening of skin. Anytime you do a radio frequency, you can get some fat loss. So the important thing is, which radio frequency can I do that will tighten my face enough that I'm not going to notice the fat loss? I get such a small amount of fat loss, bigger amount of tightening and thickening. So Profound is one of those. Morpheus is one of those. And that's about it. Those are the only ones that really give big amount of tightening without causing fat loss.
Yeah, we've got the Morpheus.
Yeah. So that's what you use Profound for. It can slim the face. It can tighten it, better jawline, everything. And that way you avoid doing buccal fat removal or less buccal fat removal to keep them safe. And I've saved, I think, if I can think of right now, at least 50 people like that who are young models in their 20s. And they're either actual modeling, Instagram modeling, actresses, and they would have been damaged otherwise. They would have turned into a Hadid, where the Hadids have, beautiful faces, but they look 10 years older than they are. And that's not a great thing when you're 24 and you're looking 34 or 35, and then you're going to look 50 when you're 40. It's not great. So that's what I try to save them from. When I go into a facelift, it's a little different because some patients I know can tolerate it. I'm going to lift them and reduce their overall facial volume a little bit anyways and elevate it back up. So some people can afford to have it removed if they're rounded or if they're droopy. If they have a tonic buccal fat pad, I'll take some, and I'll take it either from there, or if they have a lot, I always take it from inside the mouth because I can get it more efficiently through there, even though I get it through a deep plane. If it's a revision, I take them out more often because usually on revisions, you'll run into the post-aggressive surgeon battlefield where you kind of come in and the surgeon did this mass plication lift, but wanted to really make it work. So they did extensive dissection, extensive suturing, grabbed everything, and the buccal fat pad becomes attached to a different area. Buccal fat pad is normally a free-floating structure.
Yeah.
It's not attached to anything. It becomes attached to the dermis or to the SMAS instead of having a fascial plane between it and the SMAS. And now it's adherent and you can see it drooping. And even if you lift, they still have a little nut sack over here, a little ball sack over there. So in those cases, I go reduce it a little bit, very small amount, because they're older. They don't need to reduce. So I just reduce it, shrink it, get it to fall back in, and then I lift. Buccal fat repositioning, it's a little difficult to get to work without tethering to the skin and that kind of stuff. So I've gone away from buccal repositioning.
That's good. So let's talk about another part of your facelift.
I haven't had a facelift.
No, not the one you do. You do your facelift. I think part of your early popularity came because you were doing some facelifts under local anesthesia on local TV out there in LA. What percentage of your facelifts do you do under local versus general, and what is your preference?
So when I was doing them, when I was doing a lot of like TV spots, I was probably doing about 40 to 50% under local anesthesia. The reason I can do that is because facelifts don't hurt. It's a easy procedure. As long as you do it quickly, you can get through it. So if you can get someone through it 3 hours, max 4 hours, you can do it under local anesthesia. The percentage of that has gone down slightly because I'm doing less TV spots and people don't search for that. And now I'm doing a little bit more IV sedation. I don't do any general. So IV sedation, little IV twilight, propofol, 2 hours and you're done. The reason to do the local, number one, because you can. If somebody comes in and they say, you know what, I'm not scared of needles. I'm not worried about laying down and my back hurting after 2 hours. I don't really need the anesthesia. If you say it doesn't hurt while you're doing it, I'm like, no, barely. So that's the reason to do it, because you can get away with it. We used to say that it really helps a lot with postoperative swelling and bleeding because you don't have any anesthetic in you. But now that we're just using propofol and you're maintaining a pretty light sedation, the bruising and bleeding and all that seems fairly similar. So I don't use that really as a reason anymore. Although 5 years ago, when I didn't have a good sedation anesthesiologist, it was. Now I have like the best sedation anesthesiologist.
That's well, sedation, general, whichever. It's still good anesthesiologist. You can't beat that.
It's amazing. Yeah, it's amazing. And the level of control he has is unlike any other. And it's amazing. So because of him, I do now 80% sedation, 20% awake. The general I don't do because, again, you don't need to. So why would I go add a little other factor of a little bit more bleeding, not much, a little bit more bruising, swelling after, not much, but definitely a bigger chance of nausea. So why would I add that on when I can just do sedation and it's no problem? And I don't like to have a breathing tube in my way.
Now, this is more for medical technical, but do you use tranexamic acid regularly in your facelifts now?
Here and there. If I have
Here
a
and there.
reason to, I'll use it. I had two patients that I was using TXA. So TXA, I put in the solution, and sometimes I give IV. And tranexamic acid, for people who don't know, it's for women with heavy periods. It slows down their periods by making them clot a little bit better. And then they started using it in joint surgery and orthopedics and neurosurgery. And then we kind of adopted it into facial plastics and plastic surgery. So I had two patients where they had this weird little ischemic response that happened afterwards, and it went away. It didn't have epidermolysis, but it freaked me out, and it happened 2 in a row. And the only things I had changed in that couple month period was TXA, and I put half a cc more of epi in my 300 cc solution. So couldn't figure it out. I was doing fine before, so I kind of backed off a little. And now I just mix in TXA when I need, as opposed to every patient.
Okay.
And
so
I give 1 gram IV and the rest.
The question came up about if people have bleeding problems. Well, actually, you don't. If someone has a hypercoagulable state, either them or in the family, we don't use tranexamic acid. Otherwise,
Correct.
It's really not an issue in most patients.
Yeah, and if they have a bleeding problem, you're not getting a facelift.
Well, you're not going to operate anyway.
Yeah.
And
so people know
it's a cosmetic operation. It's not life-saving.
Remember that before you come to me asking, because patients come in, they always ask, well, what if I get off it? What if I do this? What if I do that? I say, if you're on the blood thinner for some bullshit reason and it's just precautionary, then fine. We'll talk to your cardiologist, get you off of it, you do the surgery, you go back on it. If it's something that you need, okay, because you have factor 5 Leiden and it's real, or you have something else, this and that, we're not coming off of it. I'm not going to do a facelift on you, because when things go downhill, they go downhill in a very big way. And facelifts, you're lucky enough where you don't have to get to that point.
They could be bloody.
They can be terrible, and it can easily go to your neck. All of a sudden, your neck is expanding, and it compromises your airway. And who wants to die for a facelift? I don't.
Yep. Actually, I just have a question about how much contour you can get with neck and jawline liposuction versus facelift.
Depends on the person. But I'll tell you, I rarely do lipo by itself. I combine it. You probably just do face tight. I combine lipo with Profound, and I do them both together. Now I'm getting angulation all the way up here, around here, more so than I used to get with any lipo alone, and I can take less fat. That's the nicer part. So I don't have to go liposuctioning everything out, because people don't realize you need some fat here. If you get rid of all the fat here, all of a sudden all you're going to see is crepey skin and muscles. The muscles start to show through.
That's why I have to be careful in thin patients with thin skin. Liposuction is not an excuse for a non-surgeon to try and tighten your neck because they don't do facelifts.
Yeah, and it
It's
makes
if
you
someone
worse.
specifically has a collection of fat. It's not an excuse or an alternative to a facelift.
Yeah, it has to be there. If you do liposuction on somebody who needs a lift, and you did liposuction on somebody who just doesn't have that much fat, you've permanently banded them. Even if you do a facelift on them and they have thin skin, you're always going to have banding. And now you got to go and do Botox on their neck all the time. And they're like, why am I doing Botox? And I'm like, well, you had lipo before. It's a, you know.
But it's not just banding. Banding means to here. I've seen people, literally, you can see every
Muscle.
strand of the platysma muscle, it's the shaving muscle, every strand in the entire neck. And it's just, I mean,
it goes back to the saying.
I sent to Sid Coleman to try and put fat into the skin, but even Sid couldn't do that.
Hard. Yeah.
He was the king of fat.
Yeah. You never forget the saying, you want some cushion for the pushing. You always have to have a little bit of cushion there to make skin look healthy. Nobody wants saggy, wrinkly, like nasty, crepey skin. You have to have healthy, soft, supple skin. And part of that is that little fat layer in there. Part of that's a little smash behind it in the face. Hyaluronic, there's different components, but you can't get rid of the fat.
Okay, so we talked earlier about how I helped get you started in your rhinoplasty and showed you your first couple of facelifts before we moved on to Andrew Kano and the deep plane. And
you started me on deep plane.
Yeah, I know, but he took you to the next level.
Yeah,
I admit it. He's a great teacher. But what else you did was, how to say how we learn from our students, and you love it. I love it when someone who I teach takes things to a new level and surpasses what I do. And back when I was training when you were a resident, we used to say the lip lift is for little old ladies with wrinkly skin. You can hide the scar and a really long lip. Otherwise, it's not an operation you should be doing because it's a horrible scar.
Yeah,
and you'll deform the person. So we did them only in little old ladies and rarely. And you took this and you went to LA and you changed it and you perfected it and you improved it. Well, now it's an amazing operation. And I have no problem telling patients, well, you can either go out to LA to see Dr. Talei, or I could do it because I learned it from him.
Yeah, and and yours are perfect.
So tell me, how did you change the lip lift? What took you to the next level, and how can you do it in young patients?
The facelift changed my lip lift. So when I was with Andrew, this is 2013. He does a ton of facelifts. So what's funny is I'm doing as many now as he was then, and now he's doing twice as many as he was then. So he was doing a ton of facelifts, and he was doing some lip lifts too. And the lip lift he did, I had never seen before. I didn't know about a lip lift. Surgeons weren't performing it. And even when I went and visited other doctors, because I was visiting every time he was gone for a day, I was visiting another doctor. I'd even come to you. Remember, I'd come to your place too still. So he showed me the way to do a lip lift. And when I got back to LA, I started doing it on a couple of young people, models here and there. And even though I had learned the facelift, I didn't fully understand it until I got back to LA. And all of a sudden it just hit me. Now I get what I'm doing. Now I get the feel of it, the feel of how I'm releasing everything in the face. And I saw the lip wasn't doing that. And so I started releasing the lip more and more and more. The more I released, the better lift I got, the less tension I got, the better healing I got on the incision.
When you say release, you're talking about how far you dissect under the skin, or the depth or the layers you go to?
Both. So that took a while. So I started going more, and then I started stitching to different places. All of a sudden I started feeling something at the base of the nose. I'm like, oh shit, what's this? And I started looking it up. 2 papers in all these years talk about the piriform ligament, but none related to a lip lift. They talk about piriform ligament, one in or maxillofacial surgery, which is quoted in other ones, and then Rod Roerich's paper. So he's a big anatomist. So I started thinking, okay, well, I got to tie to here. So I went on the extreme and I started tying too much. All of a sudden patients had indents because I tied too much. And then I started realizing, okay, maybe I got to dissect more. Then I realized, no, there's another plane here, just like the face. And that's when I started getting really, really good results. It didn't take that long because I was doing so many of them. But I found a plane called the deep plane in the lip, where you're going under the SMAS. I didn't know there was a SMAS layer in the lip. Nobody's ever talked about the SMAS layer in the lip either. I go back in the literature. I look everywhere. There's an anatomic paper by Pesach and Roerich, I think, and there was another one where they were describing the SMAS layer in the nasolabial fold, how it's a scroll. Nobody else describes the SMAS layer in the lip. It doesn't exist. So all of a sudden I start looking in the surgery as I'm doing it, and I feel this layer and I find, oh my God, this is a real SMAS layer. It's a real SMAS. So I started manipulating that more and more, dissecting it more, backing off because the healing turned out to be worse. Eventually, I made it like the deep plane facelift, where I go release as much as I need to get that tension release palpable, and then I lift it up.
So go over the layers of the lip from outside to inside.
Yeah, so everybody understands here. This is the nose. So this is actually easy to show. That's the nose. The nose curves up like that. It curves up like that. This is the nose sitting on my face, sitting on my lip, sitting on my cheek. This is the nose. This is the lip. When you want to do a lip lift, you make an incision across here, and you want to excise the skin. There's a tiny fat layer. There's SMAS, which is a very strong layer filled with hyaluronic acid, natural hyaluronic acid. And then there's a glossy layer here. It's a fascial layer. And then there's the muscle. Okay, so the muscle is the biggest part of all of this. What we go do is we remove the excess, which is going to be that skin fat SMAS, take it out, release everything in the SMAS layer, roll the SMAS over the muscle so you're not scarring the muscle, you're letting the muscle contract underneath. So I took also concepts from upper blepharoplasty. You don't want to tamper that muscle. You want to leave that muscle fully functional. It's a functioning muscle. So now you're grabbing the SMAS and you're bringing it over. No tension because it rolled over it. It's not pulling the muscle with it. And then you tack that up to the base of the nose. Doing this allowed me to do it on younger patients. And we started, I'd say, popularizing it again. And the popularity is wonderful because it is a procedure that is far overlooked. It should be almost as common as somewhere close to lower blepharoplasty in terms of its need on young patients and older patients. The problem came that it became popular, and doctors thought all of a sudden that because it became popular again, it's okay to start doing it again. No, you have to change your technique. Yeah. They were doing these antiquated techniques again. So all of a sudden, the revision rate, not 1 year after I started, 2 years after I started, and 3, went sky high. I started to see all these revisions where now half my practice became revisions where these people didn't exist before because nobody was doing them on young patients because they knew better. But now it came out and said, I said it's okay to do it with this type of technique, or like Spiegel does it. Spiegel does it wonderfully, and there are doctors who are good at it.
Now you're also carrying your incision not as we used to carry them up higher, and that's I think one of the other faults because you get these little ridges or dents from out here,
big pores, scars, step ups.
Yep. So you're stopping it really almost at the curve of the nostril, and it's the way you suspend. You do those radial lines. Pre-op, so you know where to put your suspension sutures.
Right. So
help to suspend it up.
Yeah, the incision, the subnasal incision was well described. The logic behind it in the original bull's horn articles was that you're gonna follow just the crease of the base of the nose, and it was genius because you're not invading the nose. The part it didn't define was how far lateral to go, where to make your peaks, where to actually make these marks. So my article does show that, and what I saw, we're frozen over here.
Yeah.
Oh no. All right, let's see. We're coming back. So,
you were back to talking about where you made the incision and going inside the nose.
So more and more, I try to explain that you go where the nose, that person's anatomy dictates. So some people, their crease ends here. Some people it ends out here. Some people it ends there. You end where it ends. That's it. You don't go farther than that. And you have to make a nice advancement that redistributes the skin evenly kind of all across.
And you take the sutures out quite early.
Yeah, I take the sutures out at day 3 and day 5 typically because there's enough tension release that it's not going to be pulling. And then you have enough deep stitches. You have 9 deep anchoring sutures that allow it to heal quickly without any tension. So I take them out quickly. You don't leave any marks, less chance of scarring. But again, the big problem I see is revision rates have gone up. And that's because people are still using the old techniques. Just because it's popular again doesn't mean it's okay to do it all of a sudden. You can't come out of the dark. You have to change the technique. You have to do better techniques. And it doesn't have to be mine.
Well, that's like people thought who were afraid to do rhinoplasty when they learned the open rhinoplasty, figured because they can see the cartilage makes them a better surgeon.
It's more complex than that.
Yes. Good. So actually, we had a question. Is this 2 questions or so? One is this can you lip lift on a man? I know your answer. Yes, you can.
Oh yeah.
And the other question was, someone said they heard about some internal lip lift. I'm not sure what that is. Maybe you've heard about it.
Yeah. So As far as doing it on men, you can absolutely do it on men. It does not feminize a man. It will just make the lip shorter, make them more balanced, give them more tooth show. On men, they get a huge difference in how old they look to how young they become from that without looking operated. And they actually can get back to life faster because they can grow facial hair on it while it's swollen. As far as the internal lip lift goes, somebody asked me the other day, is there any other way to do a lip lift? I said, the only other way to do a lip lift is to put your finger on it and hold it. And that's it. There is no other way to do a lip lift. And I'm positive of this. It is not my bias. It's not my weak opinion. It is a certainty. There is no other way to do a lip lift. Well, I'll make one exception, is if a nose is extremely tautic and you resuspend the columella. And that will
so the people who think they're going to stick a thread in there are deluding themselves.
Oh my God. So
I wasn't going to bring it up, but okay. So threads are out of the bag.
Yeah. So we are taught to be diplomatic in medicine for the, I'd say, main purpose. Well, there's legal purposes as to why you should be diplomatic, but because we don't always know everything and things change in the future, and maybe somebody else knows something you don't know, or we do get different results with different practices and hands and stuff like that. This is a situation where definitively, again, without a doubt, without any question, there is no benefit to putting threads in lips. And if there's no benefit, you are now in violation of Hippocratic Oath, because anytime you touch somebody, you put them at risk. And your first goal in all of medicine is to do no harm to somebody. And if you're touching them with no benefit, you can only do harm. And I don't mean to have people go blame their doctors for doing stupid things, but this is one of those things that has zero possible benefit, that can never be shown, has never been shown, will never be shown. And I wouldn't open my mouth unless that were a certainty. It will never come back to bite me in the ass because I'm so positive. So I tell people never do threads. Because
and now we're talking about not just lip. Now
no,
how about threads in the lip? Okay, now let's extend it. How about threads for the face?
I don't like them personally, but I can see the argument in using them. So very different topic. I'm okay with people using them because they might come up and say, you know what, this is a patient here who can't get a facelift, is not going to get a facelift, has very thick layers of skin. You won't see irregularities from threads now or in the future when they fibrose. I can figure out a way to justify it. Okay. And I could be like, okay, do it. Personally, I would never put one in somebody's face because I have better ways of doing things.
Plus, they last how long?
Well, if they work well, they last about 6 months to a year and a half. And it depends on the patient, and they're usually combined with doing fillers. If they don't go well, and they're different types of sutures, it can last like 5 years, 6 years. But that's how medicine works, and that's how it works with threads and barbs and things like that. I take out threads in the lip all the time. And most doctors understand this. That's why you don't see threads in the lips. And when you see threads in the lips, you see a shitload of threads in the lips because that doctor was so wrong, so off, that they have no limit on how crazy they're going to go. And they just put all these threads in place to try to lift it, thinking in their head, somebody told me it forms collagen. That's my reason. Nobody proved that to you. Nobody showed you that it forms collagen. So your assumption could very easily be wrong, and it is wrong. But that's their justification, is that, well, it dissolves. It's not permanent. Mm-hmm. My very strong argument is, yes, the scarring you formed is very permanent. So the thread may not be, but the scar that you formed and the limitation of mobility is very permanent. Not everybody, but a lot of people. So in the face, I tend not to use them, but I'm okay with it. The brow is another area of extreme stupidity.
We're talking about the
tail
thing going on here.
Size, the fox size. This is, again, definitive. And I don't mean to sound arrogant, but I didn't train in the middle of the fields of I don't want to say Philippines because it's a lovely place, but like I train in a very good place, and I have very basic, good, broad, common medical knowledge. Not even my like highest knowledge that I've gained over time. My basic medical knowledge from the first day of my residency would tell you, you don't do stupid things like this. Putting threads in the brows. There is no possible benefit for it unless you're doing a surgery at the same time and you can come up with a reason for it. If you don't release that area, all you've done is you've compressed an area that has dynamic motion. This needs to move. You can't go and compress it and give it nowhere to move and scar it, possibly hit a nerve, and then it just falls back down.
Yep.
Looks
Mike Nyack.
Yeah, see, Nyack knows this stuff. Nyack's great.
Nyack's the genius. Middle of the country, not facelifts, neck lifts. Necklace, he's the king. Mike Nyack, he just lives in St. Louis. That's all.
that's the only
actually, that's a great place. St. Louis is a great place. My mentor is from there. So let's go back to your facelift. Now, you call it the AuraLyft. And what changes or modifications have you made on the facelift that are different than the deep plane facelift that you learned or other people teach?
So it starts with, we'll start with Sam Hamra's deep plane facelift, because that's probably the most commonly practiced in the deep plane world. What you're doing is you're kind of drawing a line out here where the muscle of the platysma drapes onto the neck, and we're dissecting skin out to there. You want to limit your skin dissection as much as possible, which is different than prior kind of thoughts. But you release the platysma over here, and then now you can grab it and bring it up, and they do different types of release in the midface. The modifications that Andrew made came from what he had initially learned from Vito Quatella as an extended SMAS technique, and he got comfortable with that midface dissection there, but then took on Sam Hamra's lift and started extending that, and it became a modified extended deep plane technique, or the MADE technique that he talks about, where he's actually extending farther forward here, so under the platysma all the way here, down into the neck, releasing the cervical retaining ligaments off the sternocleidomastoid. So now you have a free open flap there, and then going in the midface over the zygomaticus minor, major, and risorius kind of coming all the way over here. So it releases everything above the mimetic muscles of the face. So the smiling muscles stay down, everything else comes up. And the reason this is a great plane to dissect in is because it's an avascular plane, largely in the lower parts over here. In the midface, there's some two major vessels that bridge across here, but it's largely avascular. So it's a less traumatic plane to dissect in. You don't have to go cut. You can go actually spread, and it opens up. Doing that releases everything and brings it up. The changes I've made since then, we've actually paralleled in a lot of the changes in the past 7 years. We both kind of changed the way we dissect in the neck, did some back cuts, stopped doing back cuts, went back to normal, started doing some digastric, backed off that, tried different things. The change that kind of stayed is I've changed my incision placement a little bit. I've changed my temporal dissection, and I did all this by changing my mid-face dissection. So the deep plane entry point is from here to here. I changed it to something called a sailboat. Sailboat means this is all going to lift up over here. This is going to lift up over here. I want my SMAS touching my incisions. So I want everything to be composite as much as possible. And the person who taught me composite initially was you, actually, when you came and gave a lecture at Columbia that I invited you to. And you taught everybody the difference between a deep plane flap and a real composite. You said, no, a real composite starts all the way back here, right? So this is as much as you can get towards a real composite. And it took me a lot of facelifts to understand how that design should be made. But it's simple. You draw your deep plane entry point. The platysma is always going to come up all the way to the tragus. And then you measure that space, and you just leave that space gap over here so everything come up. So you have a sailboat now. What you have now...
sort of angles here, slightly backwards here. So
straight up and forward.
Always, the distance is always the same.
Always the same. And it's going to come up roughly 60 degrees. We know that. Roughly 60 degrees, roughly along the zygomaticus tract, also perpendicular to the nasolabial fold, which is how I've been kind of describing it in in conferences. So everything comes up like that, and you want to leave enough space that the SMAS is going to go up to the hairline. What that does compared to the regular is now you have better vascularity at the end. You have less tension on this part of the incision, meaning you also have to do less dissection here. The less dissection you do in this area, the less kind of traumatic skin change you get. This area is very sensitive to dissection underneath. So I don't have to dissect as far anymore over here. I get the same volume displacement, and now I'm actually getting more volume on the zygomaticus, on the zygomatic arch. So I have a tiny bit more volume here from where the SMAS was left in place. And it's also a thicker SMAS, so it's easier to get into your deep plane for people who are just starting.
So when you approach your zygomaticus major, you're instead of coming that way, you'll come from this angle more.
I'm coming from farther back.
You're further back.
I'm further back, and it's actually the zygomaticus inserts all the way up here.
Yeah.
So it's actually nicer to get it here. And if you're a beginner, it's harder to transect the muscle, because some people do get under the muscle accidentally, and they start bleeding, and then weird smile later and they don't know where it came from, it's because they actually traumatized the zygomaticus minor or major. They always think it's the major. It's actually the minor probably that they're damaging because it's right under the orbicular layers.
Of course, the detractors who do SMAS lifts and like they'll lift the skin up a long way. They sort of cut SMAS and elevate for like a centimeter until they get nervous. Then they stitch it back.
Yeah.
They say, oh my God, there's risk to the facial nerve. Where is the facial nerve that they're so worried about?
So there's risk to the facial nerve if you're not experienced in it. If you haven't watched enough and you go do it, you don't know the plane. Yes, there's a big risk to the facial nerve. If you know what you're doing, your risk to facial nerve damage is actually slightly lower. And it's because you are in a plane that directly can identify where the fascial plane is that covers the facial nerve. So you keep it protected the whole time. And if you ever see it pop up, you've identified it. You never, and that's only down here. You don't ever see it here because it's under your muscles. It's protected. Down here, you can see the cervical branches. So you just don't cut them. You're doing blunt spreading. If you're good at it, you never do that. The big benefit there is you're never going to accidentally throw a stitch in it. So being a deep plane revision specialist, all I see all day long is revisions with stitches that are thrown into the nerve, around the nerve. And then afterwards, I asked the patient, I'm like, yeah, did you have weakness last time that, you did this? He's like, oh, yeah. My mouth was weak for like 3 months on that side. Or yeah, I smiled weird and my smile never came back. And it's because their entire zygomaticus is entrapped. And they actually stitched the zygomaticus and pulled it up. And you can't do that to mimetic muscles, which is, again, why in the lip lift, I try not to mess with the muscle itself unless I have to.
Okay, now how often do you do brow lifts with your facelifts in general? What percentage would you say?
I'd say probably 50 to 70, because most people, not everybody, most people who have had descent of the face will have some descent of the brow. And the way I do a brow lift, I can control very, very well how much the brow comes back up with it. The big advance I've made is realizing I want to make people look softer and not skeletonized and not surprised. And part of that is sometimes accepting a little bit of drooping, because this person has hollowed out so much that even if I refill them with fat, if I take them up, I'm going to be exposing the skeleton. Even if I refill it with fat, I have to refill it to the extent where they get really big and fatty face, which is not my style. So those patients who are kind of that borderline, I say, I'm not going to do a brow lift. I'm going to go in, I'm going to add a tiny touch of fat here. I'm going to do a fat repositioning blepharoplasty on you. And you're going to do Botox. Oh, doctor, but I don't want to do Botox. I go, well, tough shit. You come to me, you're going to look natural. You have to keep it looking natural. I don't want to make you look surprised. Oh, but I like a highbrow. I understand you like a highbrow. I want you to look soft and pleasant. I want people to like to look at you. I don't want them to look at you and feel kind of uncomfortable. And that's what happens when they overlift the brow. Now, with these endoscopic brows and the way you do it, the way I do it, you can control it. So when I do it on somebody, there's no way anybody's going to know that it was done. I just now have changed my kind of selection criteria for it.
And endoscopic is brow. That's your preferred brow, endoscopic
technique. So it's like, so I don't actually use an endoscope.
That's a whole nother talk. But
I use a finger bang. It's a long story.
But you're still in the same level on top of the bone as the endoscopic here, and right on top of the fascia on the lateral.
Correct. Yeah. Same exact level, doing a bigger release than I used to do. Again, following the same tenets of lifting. All lifting has to have release or it will not stay. So you have to go release the tension in the brow and actually release. This is something I learned from Nyack. So Nyack was actually lecturing on this a while ago, where he takes his scissor down over here and does those big kind of spreads around the edge. Calvert was talking about it too. And then I think Neil Gordon at a point. But Nyack is the first one that I saw. And I started taking my instrument down, releasing, coming all the way around. And now I get this super easy, low tension lift where I don't have to go drag the scalp too hard to try to get it anchored into a bone tunnel. I can do it now with lower tension, less hair loss, no hair loss. And the other big thing is they don't get that atrophy there that you usually get with those incisions. So I throw in bone tunnels and I can put the incision anywhere I want now. But thanks.
So we actually have only about 10 minutes left. And we've just been talking to each other. It's great to talk to you, Ben. We don't have these conversations like this at meetings, but we'll spend about 5 minutes talking about this. Then we get to the fun stuff, but that's not what this is about today. Yeah.
But no, we should talk about the fun stuff. Let's.
Unfortunately, I could not. I was trying to find the slideshow I gave when you graduate. When Columbia residents graduate, they get to select one faculty member that will toast/roast them. And Ben selected me. And it was probably one of the hardest talks I've ever had to put together. No, but really, it's great. It was like, to me, Ben was like the son I never had. I have two daughters, and Ben was the son I never had, and that was actually that was the conclusion of my of my talk. I actually showed some ink blot DNA something, said, oh, matter of fact, we happen to find something that got him DNA test, and turns out he is my illegitimate son.
Yeah, I remember that. Yeah, and funny enough, in my family, like they don't remember anybody. Anytime I mention your name, everybody's like, "Oh my God, how is he? How is he?"
Yeah.
And you're the last person who went on my boat before it sank.
Oh, I wasn't me. It was the guys who fixed it. And it wasn't my daughter driving it the way she drove it.
Yeah, she was a safe driver.
Yeah.
Do you want to? We have a couple of questions if you want to answer
Sure,
them.
absolutely. So go ahead. Let's shoot. Can you do lip lift and rhinoplasty during the same surgery? Absolutely can.
Absolutely, yeah.
And some people, I believe, you use the different incisions. Some people will use the same incision. Is there a difference?
Yes, you're at much lower risk to any nasal tip compromise, especially on a revision nose, if you're doing regular standard incisions. I tell everybody, and the research that was done for the blood supply to that area is on a standard transcolumellar incision. So make the incision in the narrowest mid part of the columella. On revisions. You always want to lean towards the tip, not the base, to get really that blood supply able to come all the way down, because this is the first place to necrose on somebody with bad blood supply.
Yep.
And you make a separate incision for the lip lift, totally fine, heals fine. Just don't do too much of an Illar-plasty, meaning you can't bring the nostrils in too much at the same time. That's going to screw you because they're going to fight each other.
Yep.
So I do that kind of later on.
Question: do you ever do closed rhinoplasties? Yeah, absolutely. I do closed rhinoplasties, and you do some also. It's for a straight nose that has subtle hump reduction, subtle tip. Absolutely, you can do closed rhinoplasty.
Yeah, so I trained with you, and I did so much closed actually when I started, and I pushed it to the limit of closed, and revisions and this and that. Now I've left it as like I do closed on these simple little tiny touches. Anything else that I'm going to deconstruct, I'm going to do open. And the way I've looked at it for surgeons to understand is there's no argument here. You do whatever works for you. But the pattern of what works for people, the lowest revision rate seems to be that the people who deconstruct the nose the least, who have like attachment techniques, meaning they don't dissect a lot, they do closed better because things are left attached. Your predictability goes higher. People who like to detach things and put in a lot of grafts and do all this stuff, they do better open because you have more control over putting it back together once you've detached or destabilized the natural structure of the nose. And I've kind of left it at that for everybody who argues about it. I'm like, there's no argument. Who cares about the incision? Who cares about the healing time? You have more predictability. That's what matters. And you have more predictability if you're not a destructuralist. And I'm a destructuralist at this point. So.
Right, and the question is, if I choose to get upper or lower blepharoplasty, will it affect the later facelift? Well, if you need a bleph, get a bleph. You need a facelift, get a facelift. You got to do what you need. You don't do something to tide you over.
Yeah, that's also what I tell people. When doctors try to tell me, well, I get a fast healing time out of this, that's why I do this shitty facelift. They don't say that. They say that's why I do this kind of facelift. In my head, I'm thinking, you can't operate on somebody and change their body and put them at risk and do all this if you're not going to give them the best result. And this is what Andrew used to say over and over again, because I would have that mentality too. I would come in and say, you know what, but you could get a quick healing time just by doing this little thing. And I didn't understand facelifts. Now I realize you do it right, you don't do it at all. I've had so many actresses want to do a lip lift, and I tell them the reality of 3 weeks, 3 months. They back out and like, you know what? I'll do it 5 years from now. I say,
got to tell them
3
weeks hiding, 3 months till you're normal smiling.
Yeah, and doing this, I've had no problems. Everybody understands the reality of it. I haven't ruined anybody's career in acting because they know, and they're not going to come back with a scar. And they're so beautiful already. You can live a little bit longer with, this longer upper lip. So, questions about how drastic of a change you're going to get with lipo of the jawline instead of a facelift. The big answer to that is completely different surgeries. So facelift's always going to get you a lot more. Lipo is more to kind of tuck in this stuff that I have. And lipo generally should not be done too much above the jawline. This is facial fat that you need. This is facial fat that kind of gathers and you can sacrifice a little. So don't let people lipo your face. That's a bad move.
Can you widen naturally narrow nostrils? That's a very difficult thing to do. Now, if they've been over narrowed with surgery, the only thing you can do is really what's called a composite graft, which is ear cartilage and skin in there which is not attractive if you look inside the nose, or a Z-plasty. But either way, it's a lot of scarring. So even naturally narrow noses, I'd say live with it. I'd leave it alone, because a natural narrow nose is a attractive nose. People spend a lot of money to get naturally narrow nostrils.
Yeah, I would say the same exact thing. The only way you'd want to widen a nose is if there's some major issue, like some kind of cancer defect that closed and it's scarred and it's cicatricial narrowing, that kind of stuff. But naturally narrow nostrils, do not try to widen them.
Okay.
Unless they're pinched. If you're talking about pinching, that's different.
Yeah. But that pinched nostril, that's different. That's more deep alar creases. Where you have a deep crease here, it's not necessarily the nostril is pinched in.
Yeah. So we have
maybe a big area talking about the ponytail lift.
Yeah,
So,
that's the same thing.
That's an hour.
Yeah. The brief is that the ponytail lift is done by Chachi Ko. It's an endoscopic lift combined with other techniques. So it's endoscopic release of midface, brow, all this stuff, little fat added in. Different plane that you're lifting. You're going subperiosteal. You're getting kind of a lift that's deep, doesn't really roll over the top part, and then he modifies it as needed. He does other things sometimes.
But for jowls and a neck, that's not going to get down there. This is more for the upper face and a little bit of tightening here. But you have significant jowls, the ponytail is not going to get that up.
Right. He's got tricks though. So Chachi has tricks.
No, with additional procedures you do, he adds to it.
Yeah. Chachi's got a lot of tricks. Other doctors don't when they're trying to do that kind of stuff. Generally people can't pull off what he pulls off. So, but the deep plane is a different technique in general. If you look at the results, they're a little different, and then you kind of pick what your aesthetic is. His aesthetic has probably a little bit more soft tissue volume. Mine has like a little bit less or more shadows kind of left over, but it's like less volume. That's really like the difference in aesthetic. But if you look at all the photos, you see, and it becomes a preference at that point, because he's like a really good surgeon, top surgeon, and he's got great results. I like the way I do it. That's why I do it my way. He does it his way. We like two different slightly things, but we agree on everything. When we talk, we agree on the logic of everything that we do. And it's just painting a different painting. That's all it is.
Yeah. The question about how we treat deep alar creases, that's when this is a little pinched in here, maybe natural or post-surgical. And we either need to graft it with something called alar strut grafts. Sometimes if the cartilage is too vertical, we'll bring it down with repositioning. So there's a number of ways. So it generally involves some type of grafting. And if the nose has not been overly skeletonized, we often get that from the septum, maybe ear cartilage, and sometimes even rib cartilage. Again, this is a lot of things. I'm like, another thing, the nose, I'm obsessed with alar creases.
Yeah, and even soft tissue grafts, sometimes, if you have somebody who naturally has like a very deep crease and you don't want to put too much cartilage so they don't feel it there, I taper off my graft as it comes in. I put a little soft tissue graft over it, and it actually cushions it without ever feeling that little step off. So there's a lot of things you could do, but the general response to that is just adding volume back there or structure.
Okay, so we've got another 2 minutes left. Any parting words that you want to say now that you're on the receiving end instead of giving end?
Also, multiple meetings.
You're catching instead of pitching.
Yeah. No, I'd say I'm very appreciative of you, and every time you talk to me with these kind of things, I always feel like the kid. I always feel like the child and and you kind of got me and everything. So it's really like I feel like I got somewhere in life when you're asking me questions and actually like listening to me instead of correcting me. So that's nice.
Correcting you, listen, I want to find out what you have to say, because I learn a lot here.
Yeah, and I remember the Fridays when I was coming in, working nights at Cornell, and I come work days with you, and we get to like Friday, and you look at me, you're like, "Are you kidding? You need to go home. Go home." I just feel like unconscious eyes rolling back. Yeah. So we are at 30 seconds left. So for everybody, I'm going to put this up as well on the podcast. Dr. Pearlman is going to have it on his as well. So if you have any questions for either of us, Dr. Pearlman is located in New York. I'm over in LA. Feel free to send us any messages or to our office. And you're doing virtual consults too, right?
Yes, I am.
Yeah. So we're in the virtual world.
And actually, I sometimes I put a tie on, sometimes I don't. My wife yells.
He's not wearing pants.
I left the tie off today.
All right. So we're counting that. All right. So thank you so much for interviewing me.
Bye.
Take care.